Thank you, Dr. Stern, for introducing me, and also thank you, Larry Johnson, for planning this event as well. This took months of planning, and we're very grateful for that. Um, and this program is going to be educational and hopefully inspires people to talk to the men in your lives, to be an advocate when they talk to their doctor, when they're having their annual physicals, um, for that. So, um, or do you have anything else, Dr. Stern, before I start the video with Dr. Wason? Well, we will answer questions at the end as well. And if you're watching on Facebook Live, if you have any questions, just put them in the comments. Either Julie or I will keep an eye on that as well. Before playing Dr. Wason's video, he's not able to join us, but he did provide his video. Dr. Wason is a faculty member of the Division of Urology and associate physicians at Harvard Medical Physicians Bilton Center for Special Care, Needham Urology. Associates, Beth Israel Deaconess Medical Center, Beth Israel Lahey Health, Harvard Medical School. Dr. Wason will be reviewing advances in screening and diagnosis. Julie, if you want to play his video, that would be appreciated.
My name is Sean Wason, and I'm a faculty member in the Division of Urology at Beth Israel Deaconess Medical Center. I primarily work out of Milton and Needham hospitals, and I'm a part-time lecturer at Harvard Medical School. I was asked to give a talk on advances in the screening and diagnosis of prostate cancer. I have no disclosures related to this talk. We all may know someone that's been affected by prostate cancer. For me, it was my grandfather, Ernest Wason, who grew up in the sunny island of Barbados, the easternmost Caribbean island. I dedicate this talk to him. The objectives of my talk are to review the goals of screening. Who do we screen? When do we screen? How do we make the diagnosis? And how are we using imaging and biomarkers to screen our patients? Typical patient that may present to me in my office for prostate cancer screening. He's a middle-aged male. He has a strong family history of prostate cancer. Notably, his grandfather died of metastatic prostate cancer, and he has a brother who was recently diagnosed with localized prostate cancer and is undergoing treatment. He has no significant voiding symptoms. He feels well. He works out frequently. He does have well-controlled hypertension, and he takes medications for this and a statin for his elevated cholesterol. He drinks alcohol occasionally. He doesn't smoke. He's married, and his erections are normal. He was noted to have a relatively normal digital rectal exam that was round, smooth, slightly enlarged, but his PSA was 4.5 nanograms per milliliter. I like to review the prostate anatomy with patients. The prostate is typically the size of a walnut, measures about 30 grams, and is part of the urethral channel. It's tucked in between the bladder and the rectum, and the backside of the prostate can be palpated by performing a digital rectal exam. The function is a reproductive organ, and it contributes to semen. What we do know is that prostate cancer is common. It affects 1 in 8 men in the United States. If detected early, the 5-year survival rate is nearly 100%. The goals with prostate cancer screening are to minimize the detection of non-life-threatening cancers and maximize the detection of intermediate and high-grade cancers, as well as decrease the unneeded biopsies and treatment. As established by the American Urologic Association on the early detection of prostate cancer. What we mean by early detection is screening, and both imply detection of a disease at an early pre-symptomatic stage when a man would have no other reason to seek medical care. The panel recommends against PSA screening in men less than the age of 40. In this age group, there is a low prevalence of clinically detectable prostate cancer. The panel also does not recommend routine screening in men over the age of 70, unless they are in excellent health and they may benefit from screening. The panel strongly recommends shared decision-making for men in between the ages of 55 and 69 with either a primary care physician or urologist, and then proceeding with screening based on a man's values and preferences. How do we find prostate cancer? The two most common ways are a blood test measuring PSA or prostate-specific antigen, as well as a digital rectal exam. Screening is best performed when these two are taken in combination. Typically, PSA and digital rectal exam are done annually for screening, But this does not tell you if someone has prostate cancer. You need a prostate biopsy in order to make the diagnosis. PSA stands for prostatic specific antigen. It's a protein in the semen that liquefies the ejaculate. It circulates in the blood of all men with intact prostates. The good news is PSA is only made by the prostate. However, prostate levels can be elevated for several reasons, such as inflammation, trauma, or natural enlargement as men age. I think a lot of men need to know, what is your PSA and what is the trend? What is the velocity? How quickly is it rising? It's one of the earliest known biomarkers used in urology. It's used in several phases of the disease, including screening, diagnosis, after local treatment, in advanced as well as metastatic disease. In regards to PSA screening, from a urologist's perspective, most would agree that mass screening is in the past. PSA does have several limitations. It's not a definitive test for prostate cancer. Shared decision-making is important. High-risk patients, such as those with first-degree relatives and family members, should be considered for screening. Age and comorbidities will often dictate who gets screened, which is also dictated by primary care providers. Who gets biopsied and diagnosed is often dictated by urologists. The National Comprehensive Cancer Center also has their guidelines on the early detection of prostate cancer. If a PSA is less than 1 nanogram per milliliter and there is a normal digital rectal exam, repeat testing can occur at longer intervals. If a PSA is in between 1 and 3 with a normal digital rectal exam, repeat testing should occur at 1 to 2 year intervals. If a PSA is greater than 3 or there's a suspicious nodule on digital rectal exam, the PSA should be repeated and this patient referred for possible biopsy. In these patients, we would consider the use of multiparametric MRI as well as biomarkers. If there remains a high suspicion for prostate cancer, these patients should undergo prostate needle biopsy. If there's a low suspicion for prostate cancer, the PSA and digital rectal exam can be repeated at a shorter interval. In my practice, I often use transabdominal ultrasounds to determine the size of the patient's prostate. By taking the PSA divided by the prostate size, we can determine the PSA density. The denser the prostate is, the more concern there is for prostate cancer. Biomarkers available for risk stratification in patients with suspected or known prostate cancer. Biomarkers are biologic molecules typically found in blood, urine, or tissue that can be used as a marker of normal or abnormal processes within the body. Biomarkers can be used in all aspects of patient care. It can be done before a biopsy, prior to repeat prostate biopsy, after biopsy, or post-treatment. Biomarkers should, however, not be routinely used in all patients. I use SelectMDx, which is a urine-based biomarker in my practice. I will use this for patients that have had a negative prostate biopsy in the past. Those patients with a very large prostate with a smaller concern for prostate cancer, and those patients that may be in the gray zone or hesitant to proceed with prostate biopsy. The assay looks for two genes, HOXC6 and DLX1, that have been shown to be associated with prostate cancer. Findings associated with the digital rectal exam, the PSA, the patient's age, and the prostate size are combined into a report that tells us the likelihood of finding prostate cancer upon biopsy, as well as, more importantly, the likelihood of detecting a clinically significant prostate cancer, which is considered a Gleason 7 or greater. I will also typically use multiparametric MRI frequently in my practice. In patients considering a prostate biopsy, all patients will undergo a multiparametric MRI, which stands for magnetic resonance imaging. There are several sequences performed in the MRI, and we can evaluate the MRI for suspicious areas within the prostate if there is evidence of extracapsular extension, seminal vesicle involvement, lymph node involvement, or possible bony metastasis. The radiologist will give us a score, PIRAD score, from 1 to 5. And I think it's extremely important for men to know, what does my MRI show? Does it show any PIRADs 4 or 5 lesions? And where are the lesions? Another imaging modality that is currently being employed is micro-ultrasound. This is a high-resolution ultrasound probe that provides real-time images similar to a standard transrectal ultrasound. This can be used in both the initial biopsy phase and the surveillance phase on patients diagnosed with prostate cancer. The images provided by micro-ultrasound are far superior and can provide detailed local anatomy. It also has a very similar scoring system to the PIRADS system called PRIMUS. The higher the number on the PRIMUS score, the higher likelihood of finding clinically significant prostate cancer. Prostate biopsy is typically performed transrectally, and the goal is to sample the peripheral zone of the prostate. On average, 12 cores are taken, 6 on either side, in the peripheral zone of the prostate. The prostate biopsy will tell us, is there prostate cancer or not? What is the Gleason grade, which is the aggressiveness of the prostate cancer? Gleason 6 prostate cancers are the least aggressive, whereas Gleason 10 prostate cancers are the most aggressive. The prostate biopsy also estimates the volume of the cancer, the number of cores involved, what is the location, and if there is perineural invasion, which is a poor prognostic indicator. There are 2 standard ways to perform a prostate biopsy. One is via the transperineal, and the other is via the transrectal route. Both are typically performed in the office, under ultrasound guidance, by a urologist. The added benefit of performing the transperineal biopsy is that anterior aspect of the prostate is more easily sampled. There may also be a slight decrease in the risk of infection via the transperineal route, although recent data is questioning this. Multiparametric MRI ultrasound fusion is a technique used to sample lesions noted on MRI. After the MRI is complete, the radiologist will encircle the lesion on the MRI, and then these images can be fused in real time to a standard transrectal or perineal ultrasound to ensure that the lesions that are noted on MRI are sampled. As prostate cancer can be found 15 to 20% of the time in other areas of the prostate without a lesion, usually the fusion-guided biopsy are also performed with the standard 12-core needle biopsy. After the prostate is sampled, the cores are all sent to a pathologist for evaluation and are given a Gleason grade, which ranges from 6 to 10, 10 being more aggressive. Patient needs to know, what is my current Gleason score? Once we know the Gleason score, the number of cores involved, the PSA, the digital rectal exam finding, the patients are given a risk category ranging from very low, low, intermediate, high, and very high risk. This will determine the extent at which imaging studies need to be performed for evaluation of disease outside of the prostate. In patients with low and favorable intermediate risk disease, genomic biomarkers can be performed on tissue removed at the time of biopsy. This will determine the biologic aggressiveness of the prostate cancer. This is useful for patients considering active surveillance. In patients found to have unfavorable intermediate risk, high risk, and very high risk disease should undergo additional imaging to ensure that there's no metastatic disease or disease outside of the prostate. Traditional imaging includes CT scan of the abdomen and pelvis, as well as a bone scan. Although CT and bone scan are still widely being used for imaging, slowly this is being supplanted by a more sensitive test called PSMA PET scan. PSMA stands for prostate-specific membrane antigen. This is a protein found on the surface of most prostate cancer cells. A radio-labeled pharmaceutical agent is tagged to PSMA. The whole body is scanned, and this will easily identify areas outside of the prostate where there may be prostate cancer metastasis. After a diagnosis of prostate cancer, many men will ask, how can I be proactive in my fight against prostate cancer? One of the fathers of prostate cancer treatment is Professor Laurie Klotz from the University of Toronto. He recommends smoking cessation, consider a low-dose statin, vitamin D supplementation, as well as metformin. In summary, prostate cancer is common and its aggressiveness is quite variable. Earlier detection is favorable and can lead to a cure a lot of the time. Our goal with prostate cancer screening is to maximize detection of intermediate, high, and lethal cancers, minimize the detection of non-life-threatening cancers. We can do this with improved imaging and genomics, which can improve risk stratification. This has also allowed urologists and patients to be more comfortable with active surveillance. Thank you for your attention.
Thank you to Dr.
Did
Wason for
everything you thought.
attending his presentation. We're going to have questions at the end, make it easier for everybody to have enough time. I'm going to now reintroduce Dr. Stern, CEO and founder of AdMeTech Foundation.
Thank you, Thomas. I would like to, first of all, I don't like talking about it, but I would say a few words about my professional background. I was born in Ukraine. I came to this, when it was still Soviet Union, I came to this country in 1979, and within less than 2 years, I was invited to join internal medicine program, medical residency program at Staten Island Hospital. It's an affiliate of Downstate Medical Center. And I became the first graduate of this program to be invited to join Mass General Fellowship in Imaging. And I focused actually at Mass General as a fellow. I focused on MRI and molecular imaging. And then after a few years of being on faculty at Harvard, I was invited to head medical imaging research, diagnostic imaging research branch at the National Cancer Institute, where I spent 10 years until we founded AdMeTech Foundation. And the goal of at National Cancer Institute at NIH, I led development of current approaches to breast cancer imaging. This was my primary focus, and I also worked extensively with HHS Secretary Office in Washington and many other agencies. And together with many other agencies, we developed digital mammography, which is standard today, breast MRI, and many stereotactic precision biopsy, et cetera, et cetera. In 1995, my father was misdiagnosed with prostate cancer, and it became a wake-up call from, actually, I should say his prostate cancer was missed. And I was so shocked because I asked my former colleague from Mass General to take care of my father. And I was shocked that one of the best urologists in the world missed my father's prostate cancer. I would never forget the call from that urologist that my father actually ended up having prostate cancer. And the shock of that experience prompted my research. What's happening? What happened? How come my father's prostate cancer was missed by one of the best urologists in the world? And that it was at around 1995, 1996. And that's when I realized that men did not, diagnostic tools, including imaging in prostate cancer and treatment of prostate cancer was done, biopsies of prostate cancer were done blindly. It was running, prostate cancer care was running 20, 30 years behind breast cancer, which was my subspecialty. And first I took care of my father, but when sort of the shock wore off, I convinced my colleagues at the National Cancer Institute to, at least I try, to convince my colleague at the National Cancer Institute to pay attention to prostate cancer and to make it priority similar to breast cancer, because prostate cancer is just as common as breast cancer. Breast cancer strikes 1 in 8 women. Prostate cancer strikes 1 in 8 men. And in spite of my track record at the National Cancer Institute and incredible support. All the programs I proposed to NCI and breast cancer imaging were always supported. The initiative in prostate cancer, in spite of, I assembled leaders of academia and industry, and they also suggested that for prostate cancer to be the next priority because particularly in imaging, because men did not have imaging tools, everything was blind. And to our joint shock, National Cancer Institute was not willing to invest in prostate cancer. So by late 1997, in November 1997, we created nonprofit AdMeTech Foundation to provide the kind of leadership in prostate cancer research and care that National Cancer Institute was not willing to support. Another factor that was particularly did not sit well with me is that Black men were dying and still dying at a rate of 2.5 times higher compared to white men. Prostate cancer is one of the leading health disparities. In spite of all the statistics, in spite of tremendous impact of prostate cancer on the society, NCI, NIH were not willing to invest money and effort. And so we created AdMeTech Foundation to provide national leadership and global leadership of a kind that NCI, NIH were not prepared to provide. Since that time, we led development of exactly what Dr. Wason just reviewed. We led development of MRI imaging for men. Right now, it is a standard tool for men suspected of having prostate cancer or men with prostate cancer. We led also development of molecular imaging, PSMA, that was described by Dr. Wason, that is also a standard tool. And we are doing a lot of research in order to take prostate cancer treatment to the next level at the moment. Our original funding were coming from the federal government. Our current funding is coming from the state. I would like to sort of refocus a couple of points that Dr. Wason had made. One, he mentioned that a general recommendation is for men to start screening between the ages of 55 and 69. This is for average risk men who do not have family history of prostate cancer, who are not Black. For Black men, it's really important for Black men to start talking to their doctors at the age of 40. 1 in 8 American men get prostate cancer. 1 in 6 Black men get prostate cancer. So it's really important for Black men to start talking to their physicians about the right time for each individual man to have screening. Why screening is so important, Dr. Wason pointed out. Without screening, we cannot achieve early detection, which is critical for saving lives. And we can apply much less aggressive tools in treatment. The earlier we detect prostate cancer, the less aggressive treatment we may potentially apply. Dr. Wason also mentioned a couple of treatment approaches we have right now, and I want to sort of clarify a couple of them. The main choice right now is between careful observation, when we do not have to do treatment at all. We just can carefully observe men because they have the kind of prostate cancer that is not likely to progress and cause symptoms. We call it active surveillance. And another option is very aggressive. It is called radical prostatectomy or aggressive radiation treatment that covers the entire area of the prostate. Right now, we are working, AdMeTech Foundation is leading efforts in developing minimally invasive treatment, focal treatment of prostate cancer, just like in breast cancer, we have an option, and most women right now have minimally invasive lumpectomy when a small part of breast is resected where cancer is. We no longer in most cases are doing a radical mastectomy. Men still have mostly radical treatment, so we are leading development of minimally invasive treatment that can be administered under imaging guidance with great precision in ambulatory setting with minimal complications and minimum costs. It does not require hospitalization. That's the focus of our research right now. So these are sort of three main treatment modalities. Although minimally invasive treatment is largely experimental tool right now, there is limited access to minimally invasive treatment in Massachusetts and elsewhere in the country. Why I am saying that? Because what Dr. Wason just described, precision diagnosis, precision imaging, precision genetics, precision molecular information, allow us to determine which individual man will benefit from each therapeutic tool. Would it be active surveillance, just careful observation, no complications, minimally invasive treatment, or really aggressive life-saving treatment? So that's basically a couple of points I wanted to refocus before my presentation. Do we have any questions so far?
Are there any questions that the audience might have? If you do, write them down and pass them forward.
We've seen tremendous advances in prostate cancer care over the last 5-6 years. A lot of highly advanced imaging, genetic, molecular diagnostic tools, and some of the more advanced therapeutic approaches. Access of experts, even in Massachusetts, may be limited to these cutting-edge advances. As the result of it, we established prostate cancer equity program so that every man in Massachusetts will have access to the best experts with the best resource, diagnostic and therapeutic resources in the state, and to support men every step of the way and to help them navigate healthcare system. The focus of my talk will be on prostate cancer equity program. Julie, do you mind? My name is Faina Stern. I'm grateful to Cape Cod NAACP for great partnership in creating this first joint prostate cancer awareness event. AdMeTech Foundation is a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. Dr. Sean Wason described recent advances in patient care. The main topic of my presentation is our prostate cancer equity program and its mission to bring the cutting-edge advances in patient care to Massachusetts men and eliminate health disparities. Prostate cancer equity program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national and global leadership in public awareness, medical education and research, and health equity. We are grateful to the Cape Cod delegation to the State House that made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was initiated since 2013 in collaboration with multiple organizations and has 4 components: public awareness, community education, prostate cancer equity and clinical care, medical education, and research. Our public awareness campaign, community education and outreach, is focused on the most vulnerable and underserved individuals. Since January 2023, we reached over 15,000 underprivileged individuals. This is a 50% increase compared to what we reported last year. Since 2019, our public awareness and education program reached over 52,000 people. For public awareness and education, our messaging is centered on the importance of screening and early detection critical for saving lives. Early detection is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only 28% of men remain alive at the same time. The center of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 7th annual conference took place in September last year. Our summit has been recognized as a seminal event in shaping the state-of-the-art and future vision for patient care. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices and research priorities. Last September, we had over 300 physicians participating during this event. After the event, our media partners published over 60 scientific presentations and reached over 35,000 physicians across the globe. It's difficult to find any corner of the world that has not been reached by this event. Our summit showed that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostics and therapeutic approaches ensuring high quality, personalized, precision patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care to all. Supporting organizations include Latino Health Insurance Program and multiple NAACP branches located across the state. Any Massachusetts man age 40 and older can participate. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. We strongly believe that our Prostate Cancer Equity Program, integrated with our large-scale public awareness campaign, has been placing Massachusetts in a strong position to become the first state in our country to eliminate health disparities. Experts of the Prostate Cancer Equity Program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how doctors involved in this program take care of their families and friends. This process consists of 3 components. 1, AdMeTech Foundation's team members collect basic information and match individual patients' needs with the appropriate state experts for clinical care. 2. A clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, any insurance and financial assistance if needed. 3. If an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as testing or treatment. I'd like to share with you a few recent examples of how prostate cancer equity program has been making a difference. This is a case of a Black man with a history of prostate cancer who is currently being treated. On May 15, his doctor informed him that his scheduled treatment could not be provided due to problems with the insurance coverage. He got upset and shared his situation with Representative Bud Williams and a leader of the Men of Color Health Awareness Program, MOCA, our community partner in Springfield, who referred him to us. On the late afternoon of May 26, right before the Memorial Weekend, he contacted us and appealed for help. Our primary goal was to restore his treatment as soon as possible, and we immediately reached out to Dr. Mitchell Sokolov and his team at UMass and secured their support. On May 30th, right after Memorial Day, UMass Urology provided guidance to this man how to address his insurance. By Friday the same week, on June 2nd, the insurance issue has been resolved, and the appointment with Dr. Sokolov was scheduled at the earliest opportunity in early July to resume his treatment. The following Monday, on June 5, a MOCA leader heard about what happened and asked for a second opinion for his own urologic health issue, and received an appointment with a leading urologic expert within a few days of his request. This is a story of a Black man in his mid-50s who was referred to us in mid-May by Cambridge NAACP. This man was recently diagnosed with prostate cancer. He got alarmed when his urologist informed him that the best care will not be available to him due to his limited insurance. We connected him right away with the patient navigator at the Mass General Brigham. She obtained a referral from his primary care physician and secured approval from his insurance. 3 weeks later, by June 6, this man saw Dr. Adam Feldman, a leading clinical expert and one of our featured physicians. Dr. Feldman described various treatment options, but recommended curative surgery, which was performed in mid-August. We asked a few men to share how prostate cancer equity program has been making a difference for them. The first video was provided by Jose Javier of Lawrence, Massachusetts.
Hello, everyone. My name is Jose Javier. First, let me begin by thanking Dr. Stern for inviting me here today and being part of this. I'm excited to share with you and grateful to be able to share with you for a few minutes a little bit about my story and my experience with AdMeTech in the organization. I met Dr. Stern around the fall of 2015. I heard about her from a friend of mine at church, Victor McCain, which I'm grateful for because he was going through the same thing, and he was able to share at church, and I heard his testimony, and I was able to approach him after the service, and we had a great conversation. I was very shy about this subject. I too had a very high count of my PSA exam and had to go in for a biopsy. And I learned from Victor McCain the difference between an MRI biopsy, a guided biopsy, and also what is referred to as a blind biopsy. And those made a difference in my life. And I was able to meet Dr. Stern through this process. And I was able to go in, get a MRI guided biopsy at the NIH and so forth. And it was a fantastic experience for me. So for me, part of the takeaway when it comes to this is really to be aware. Be aware, learn about the processes, learn what's available out there, what programs are available for you, what are the best tools to do the job. A very important thing is to share it. That's what I learned from my friend Victor, is to share it at church, share it with other people so they can learn as well. And because in our community, especially in the Black American community and the Latino community, it's a subject that is not often spoke about. When we talk about our private parts and speaking about the prostate, it's not always a conversation that is too welcoming in our community. So I would encourage people to share it, to learn. And as Governor Baker always says, get tested. You know, it's easy to get tested. Ask your doctor for a test and be aware and that there are solutions out there. We have great referrals, we have great doctors, and contact the leadership, the people at AdMeTech, and they're able to guide you in the right direction. Thank you. Please allow me to say a few words in Spanish. Para nuestra comunidad en español, este tema de cáncer en la próstata es un tema súper serio, muy serio, y es un tema que nos impacta a nuestra comunidad significantemente. Yo le quería decir a ustedes que, por favor, hablen con su médico si sienten algún síntoma, si están teniendo problemas orinando, cualquier irregularidades. Hablen con su médico, no tengan miedo de conversar con su médico, hablen con personas que tienen experiencias similares y eso le puede salvar su vida. Lo más importante es hacerse un examen PSA. Por favor, estudienlo bien y aprendan más. Gracias.
The second video features Ronald Roberts, who was referred to us by Martha's Vineyard NAACP.
Hi, everyone. I'm so glad to be here. My name is Ronald Roberts, and I'm just so glad to be included in this presentation. I have known about AdMeTech, and I'd met Dr. Stern years ago, and I would have never thought that I would be needing them so much last August when I was diagnosed on July 4th with prostate cancer that had spread to about 3 organs and lymph nodes, and I was in really bad shape. I ended up talking to Dr. Stern later on, and she directed me in the right direction. I ended up at Dana-Farber and jumping around to Brigham and Women's. I'm just fortunate, I consider myself fortunate to live in Massachusetts, where the medical help is available. If you know where to go, it really paid off for me. I'm doing pretty well after going through the MRIs and using the advanced equipment was provided to me. But through the direction of AdMeTech, I got to the right places. It takes a lot of willpower and positive thinking to do and go through what I did. I ended up driving over 3,600 miles, and that was after I had a driver that used to take me when I was weak. When you add the radiation, chemo in, 34 more appointments, it comes out to a lot of appointments, and I made every one. It was nice to know there was always somebody in the background that could help out if I had, I needed an opinion, and that was AdMeTech. And to bring people like myself that are patients, been exposed to the cancer, and survivors and people from the medical field and politicians, it's something that's badly needed for the minority community. We have the knowledge there. Things have changed a lot in terms of prostate cancer for the better. I'm taking a drug that's only 3 years old that has excellent results, but you got to know where it is and you got to be guided in the right direction. It's kind of frustrating that there's so many people out there that do have it and are not getting the help or not getting the proper help. I had put it off for years. I knew back in 2010 when I had Lyme disease, relapsing polychondritis, and babesiosis, and I forgot what else, all at the same time. I tried to treat the cancer back then with chemo, and it just got worse, so I just put it on the back burner. And I didn't even feel anything up until the few months before I was diagnosed, and that was I couldn't hold food down too well. Fortunately, a lot has changed since 2010-11 when I was treated. There's a lot out there, a lot of new advanced machinery that can help with MRIs and radiation. We're fortunate in Massachusetts to have it available, and especially the Boston area. Without AdMeTech to guide you and be a resource, it's just so crucial if you need it, because sometimes you got to make a decision as to what the treatment is, and everybody's different. The reason I waited so long is trust, and that's a big thing. I have met other patients that have had mistakes or things didn't go right, and finally they got the right help, and waiting and insurance problems. And that's something that could be avoided or hopefully streamlined. And that's what AdMeTech is there for, if you catch it early. And it is so important to get tested early and continue the testing. The primary doctors should know more about AdMeTech. And one other thing, with the testing that I did do and all that I went through, what helped me, if nothing else but mentally, was getting a DNA test. My father had passed from prostate cancer at about age 84, so I always thought it was hereditary, and through the DNA testing I found it wasn't, but I do have the gene that causes colon cancer. And around December I got a notice from I think it was Dana-Farber that that gene could possibly cause prostate cancer. And DNA testing also helps for alternative treatments. So it's good to do, and it helps my nephew and all know that they got to get tested and what to look for. The good thing about all this is there's a lot of research and things are changing fast. So even if you are sick, if you can hold in there, there's more on the way that could possibly help. Once again, what I did this past year, I couldn't do back in 2011. It wasn't available. And the idea of research and studies, and you do get a lot of notices for that. Probably scares people too, because we think back to the Tuskegee study. I'm probably going to benefit from one of the studies they're going to do on me, and that is exercise in relation to the hormone therapy, the heart. So I'm looking forward to that in June. It's quite a study, quite a bit of exercise. I'm going to end it there.
Emma Couillard serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Greg McClay, a patient educator, and other members of the AdMeTech Foundation's team. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, and other clinical partners to expedite medical visits and address any needs you may have. Our team may not be able to right every social wrong that cannot be resolved by federal or state government, or provide perfect solutions for every man. And yet, we are committed to doing our best and making sure men are not left behind or struggling alone. If you have any questions about our program or need assistance, please contact Emma by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention.
All right, I will turn it back to Dr. Stern for if anybody has any questions. If anybody has any questions.
Hi, sorry, we actually have a couple of questions that Larry is going to read out.
Okay.
One of the questions is how much does your diet attribute to prostate cancer, any if all?
Can I please, are you talking about diet?
Yes.
Okay, great. I cannot hear you very well for some reason. There is no scientific evidence that would support any specific diet and its impact on prevention or control of prostate cancer. However, there is a commonsensical sort of approach to advise men to do heart-healthy diet. Whatever is healthy for the heart is good for the body. together with the exercise. It is just a exercise, and heart healthy diet is a general sort of health issues that would support men, not necessarily for prevention of prostate cancer, but God forbid somebody is streaking, their body is in a better position to fight it off.
And the next question that I have is being proactive. At what age should men of color and Latino Americans should start testing? I believe you answered that earlier on.
Yeah, I did. No later than the age of 45, ideally. The testing, but the conversation with the doctor should start at the age of 40 because there are additional factors. So to make things simple, we basically recommend Black men to start conversation with their doctor at the age of 40 because if someone is a Black man and also has a family history of prostate cancer, particularly brother or father, these people should start testing at the age of 40. So to make it simple, when you are 40, this is the time to discuss with your doctor if PSA screening is right for you. But if you miss at the age of 40, please make sure that you get it at 45 at the very least, because this reading of PSA test, we call it first or baseline PSA test, is absolutely critical for us to create a individualized screening plan for men. Depending on the level, we would recommend how frequently men would get tested and what the next steps will be.
Thank you. Are there any other questions that the audience might have?
Maybe enlarge prostate. When it's when it gets, how large will it get? If cancer will develop, can you have an enlarged prostate without getting cancer?
Absolutely. Just about every man starting at the age of 50 would have some degree of enlargement of of the prostate organ. And it gets, unfortunately, prostate gets bigger with age, prostate organ. And it is called benign prostatic hypertrophy. And it is not a risk for prostate cancer. Did I address your question? Because I did not hear very well. Yeah. So the unfortunate part of it is that symptoms of prostate cancer may be similar. So if you have symptoms if one has symptoms like, for example, difficulties urinating or something similar, or God forbid, blood in the urine, it's really important to talk to your physician to figure out what's going on.
Okay, any other questions? Thank you, doctor.
Thank you. Thank you very much.
Thank you.
Thank you. Any final words, Larry, that you have?
I just want to thank AdMeTech for the opportunity to present this very, very worthwhile program. I think I've learned a lot, and I've had members of my family that have suffered prostate cancer and had their prostate removed. So I know the scourge, and I know the problems that it brings, and I'm just glad we had the opportunity to do that. Hopefully we can do it again sometime at the latter part of the year, or if not sooner. I think we can become pros and get the word out to the community as well.
Larry, also, if anyone comes to you and shares any kind of concerns whether or not to do screening, or if they're looking for a second opinion because they're already dealing with prostate cancer, if anyone is recommended a biopsy, invasive biopsy, and they're not sure, please do not hesitate to send them to us. and we will make sure that every man will have access to the best available care, or at least a second opinion to consider.
As far as I'm concerned, doctor, you're number one on the short list. So we will be in contact with you, and I wholeheartedly support this program and will be a champion to get the word out as to everybody I meet of color and minority within our community. So thank you for a very insightful program, and thank you for allowing us to be part of this tremendous program. Thank you very, very much.
Thank you so much. Thank you. Thank you for your
everybody. Have a
partnership.
great night.
Thank you. Have a great day.
And thank you, Thomas, for your help. I
Problem.
promise I won't lose the information again.
Have a great night, everybody.
Have a great
All
day.
right,
Bye-bye.
thank you.